Good afternoon. Welcome to the DSD session working group. And we, Paul Hoffman from New Zealand and Reiko Horikawa from Japan, are going to chair this session. And Paul, would you like to say something?
Look, it's wonderful seeing you all here for this first session before the main meeting starts. We received a huge number of abstracts for this DSD symposia, all of which were amazing. And we were only able to choose 2, but the others were equally as fascinating. And it's something hopefully we can repeat in the future, because I think there's a lot of discussion points from the other abstracts as well. So I'll get Reiko to ask for the first speaker to come up here. We're going to look at having a 15-minute presentation interspersed or at the end of another 15 minutes for discussion, because I think all these cases you can look at a lot of discussion points. So feel free, we would like the audience to be involved in this, because I think the way DSD is treated in different parts of the world varies, and having other perspectives is really useful. So anyway, Reiko.
Yeah. So we would like to invite the first speaker, Shaila. And this is such a kind of informal meeting, I would say. So maybe people can interrupt during the presentation if you like.
Yes,
okay, if it's okay. Yeah. So please raise hands anytime you want and give comments or the questions.
Yes, thank you. Good afternoon, everyone. At the outset, I want to thank the organizers and moderators for giving me this opportunity. I'll be talking about 2 siblings. 2 siblings, both born to a 3rd-degree consanguineous married couple. Concern was a female-like genitalia with palpable mass in the left inguinal region. Second child was reviewed to us because it had similar presentation to the elder sibling. A biochemical evaluation was done for the elder sibling. Concern was parents is to know interest in the genetic etiology for the DSD. This is the history. The both presented at birth with the sex of rearing being female. Presently they are 3 years and 8 months old. Both were born term with a birth weight of 2.7 and 2.8, and development history till now is normal. The genital examination revealed a narrow phallus of 9 millimeter, and there was only one opening at the base of the phallus, fused labioscrotal fold without any rugosities, and there was a palpable mass in the left inguinal region. Right gonad was not felt, the EMS being 1/12. This is the narrow phallus, and this is the fused labioscrotal fold. At the last visit, when we evaluated, the anthropometric parameters didn't reveal any significant changes. One was underweight and the other was stunted. Other than that, we couldn't get any abnormal features in the anthropometry. Head-to-toe examination was normal without any evidence of dysmorphism, and systemic examination revealed normal findings including the central nervous system. No deficits were noted. So we went ahead with the investigations. The first child, the elder sibling, it was evaluated at 4 different occasions: day 4, 1 month, 4 months and 5 months. On the 1 month of age, the FSH and LH were on the FSH on the higher side, 20.55, and LH was normal. Testo was on the lower side, 30 nanogram per dl. DHT was also on the normal side, and AMH was low, 0.522, and cortisol was normal. Further, it was evaluated by a pediatric surgeons. They found the FSH kept on increasing. It went up to 127, and you can make out that the testo level gradually came down, and even the DHT level came down. So at this point, we are sure that the diagnosis is gonadal dysgenesis. And to complete the workup, we have even done the electrolytes, creatinine and 17 OHP, they were normal, and karyotyping was proved to be 46XY. The second child also had a similar presentation, and at 1 month of FSH and LH were normal. So this says that there was no evidence of gonadal dysgenesis at this point, but testo was on the lower side, and AMH was also on the lower side. Similar presentation here. All the other investigations were normal, except for the karyotyping revealed a 14p short arm satellite chromosome was there. Ultrasonography of the first child revealed a uterus-like structure and testis-like structure in the left inguinal region, and right was not visualized, and kidneys were normal. On the second child also revealed the presence of uterus, but there was some widening of the superficial inguinal ring, thought to be of inguinal hernia. They are not sure of the testis in this condition. They are not sure of the ovary. We didn't go ahead with the MRI in this child. As the first child presented earlier, it underwent diagnostic laparoscopy. It revealed bilateral dysplastic gonads, and uterus was absent here in the laparoscopy. Genitoscopy revealed urogenital sinus, one opening into the urethra, another one was having a 2 to 3 centimeter long blind ending pouch represented as vagina. Biopsy of the gonad was taken by the pediatric surgeon, and it revealed atrophic seminiferous tubules containing Sertoli cells, and Leydig cell nodular hyperplasia was noted, and the report was immature testis. Second child is still pending. So the whole exome, as a second child presented to us, we went ahead with the whole exome sequencing as a part of the faculty grant we received from the college. So it revealed a TOE1 mutation in the exon 5. It was a homozygous mutation in the C398 T is replaced by C, and it was an uncertain significance, causing etiology being pontocerebellar hypoplasia type 7. It was in chromosome 1p. As it had a similar presentation to the first sibling, we went ahead with the Sanger sequencing for the elder sibling. It revealed the same mutation in them. So, and it was, even though variant of unknown significance, we found it to be pathogenic as per the in silico prediction. So, it is a disorder of sex development. Chromosomal sex here being 46XY, gonads being testis. Phenotypic, it was a female. So, it is a 46XY DSD, complete gonadal degenesis, etiology being pontocerebellar hypoplasia type 7, mutation was TOE1 gene mutation. As we are aware, 46XY DSD is most commonly caused by SRY gene, NR5A1, SOX9, DHX37, ATRX, etc. Many unknown causes are still there, but we could get a mutation in the TOE1, that is a target of early growth response, TOE EGR gene 1. So PCH in general, it is a clinically diverse condition with varied presentation, which usually go to the neurologist, and it is genetically heterogeneous. A lot of genes are involved in that. It's a group of neurodegenerative disorders, mainly with the prenatal onset, and all are autosomal recessive inheritance. MRI shows varying degree of presentation, severe hypoplasia of the or atrophy of the cerebellum and the pons, with variable involvement of the supratentorial structures. That is why it is clinically diverse presentation is there. Currently, there are 13 types based on the different clinical features and the genetic causes, and 19 genes have been involved in that. Type 2 is the most common, and most of them have a role in RNA processing and translation. So coming to our type, PCH type 7. Similar presentation of global developmental delay, hypotonia, psychomotor problems, seizures, and here only distinguishing feature is the gonadal involvement compared to other PCH. So we have a 46XY with PCH type 7. They have undervisualization ranging from completely differentiated female external genitalia to micropenis with the hypoplastic scrotum. So in some XY patients, they have found even uterine or the ovarian remnants. Few had atrophic testis or no gonadal tissue at all. So what is the role of this TOE1? The role was recently identified in 2017. Prior that, we had one case report from India. They had XY dysgenesis, but with gonadal dysgenesis with developmental delay, and found to have a pontocerebellar hypoplasia, but not proved genetically. This was included in this study by 2017 in Lardeli et al. Study. It plays a major role in maturation of small nuclear RNAs. Humans with reduced levels of TOE1 may cause perturbation in the sRNA pools, and it may contribute to the PCH. The exact role why it does causes this both pontocerebellar hypoplasia and the gonadal dysgenesis is not known. So it may play some role in the embryonic period. These are studies from various articles. So this was the first one. It was identified by Lardeli et al. In 12 families, age range being 2 to 29 years. The others were 5.6, 10 months and infancy, and the last one was 2 year. Clinical features varied. Some had optic atrophy, seizures. In the second child, second case, they didn't have any gonadal malformation. In the third, Ibrahim et al. From Pakistan, they had a normal developmental milestones. So others had similar. Some have postnatal growth retardation, some had genital abnormalities. MRI brain varied picture. Some had just a small cerebral endpoint, some had hydrocephalus, some had enlarged large ventricle, low volume of cerebellum. All of them have studied mainly about the 46XY. As I said, the second study, Chen H et al., they found a normal genitalia. Others varied presentation of EMS 1 to 4. XX was reported only in the first study. They found out ovarian atrophy and lack of menarche. Other studies have not reported about the 46XX. These are the mutations. Some of them are proved pathogenic, some are still variant of unknown significance. So, from PCH7 from India, this is the first mutation in TOE1 causing 46XY DSD, gonadal dysgenesis. MRI brain is still pending to complete our workup. If it is normal, we could attribute this as a varied clinical presentation of PCH type 7, as both the siblings have normal development till now. So, conclusion, it is associated with the 46XY gonadal dysgenesis. They have the developmental delay, autism, and all that. As we are aware, DSD is an enigma. The panel is still expanding. With the newer genetic techniques, it can be expanded, and once we get the genetic diagnosis, individual management can be done. These are my references. Thank you.
Does anybody have any comments? You've seen a case like this? No, you haven't.
Yes, sir.
I'm interested in the slowly declining testosterone levels after birth and the slowly rising LH.
Yes,
So
yes.
this sounds like it was happening, the abnormalities were progressing even later.
Postnatal.
It's not just embryonic, this is actually progressive. Do you have any understanding of why that is?
No, sir, I couldn't get the. Actually, some of the studies have not even mentioned what is a genital abnormality. They have mentioned female-like looking genitalia, and the further details are not there in the articles. That is, there are only some 17 patients have been reported all over the world. So, not sure why the postnatal decline in FSH and LH occurs. Not aware of that.
Right. Have you done an MRI?
No, sir, it is still pending.
Right. Okay.
Both of these children had normal neurologic development.
Yes, ma'am. Yes, ma'am.
So what made you think of pontine cerebellar hypoplasia?
Yes, ma'am. So, as the second child had the mutation, we wanted to confirm for the first child, and it turned to be having the same mutation. There are reports of this associated with gonadal dysgenesis, so we thought it could be a part of PCH type 7 because one report by Pakistan, that Ibrahim et al., they reported normal development. So we're not sure when they will have a developmental delay. Otherwise, all PCH will have a early onset neurodevelopmental regression. This is not in terms with our cases actually.
Yeah, the gonad was entirely removed, or was it only biopsied?
Actually, it was removed, sir.
So then we should have more information on the histology. The histology which is described is of an immature gonad,
Yes,
I
sir.
agree.
Yes, sir.
But then to label it as dysgenesis, is there more information, or is that...
So I couldn't get the details actually. It was with the parents.
because it would overlap with so much histology of so much of the other 46XY
Yes, sir.
DSD gonads.
Yes, sir.
The LH levels at 1 month in this case were also very low, if I'm not wrong.
Yes,
They
it
were
was
just
normal.
0.3.
Yeah, it was
So
normal
is
only.
that also known in this case?
That's what I didn't get the details about all the cases. They have just mentioned only few details in the case series. There are only individual case reports about that. I couldn't get what are the values of FSH and LH in that.
Thank you.
In our country, it's not easy to get the hormonal profile, right? So,
Yes, ma'am.
was there any need for doing an AMH level?
Actually, I was doing a study with a
Okay.
faculty grant, ma'am, from the college. It was included as a part of the study. So they got a sponsor from the college. And as I was aware of the first child because I had seen the child first, and AMH was low, and that obviously I was expecting the same clinical presentation, and I just confirmed in the second child.
Right. Because interpretation also gets very difficult at this age group.
AMH of 1 digit or point 0 is suggestive of almost absence of Sertoli cell function, ma'am. At least should be double digit as per the articles, but I don't know the cutoff. Some say it is 2 to 4 is also normal, but point 0 is quite disturbing to have a. It says it's abnormal FSH function.
So, excellent cases. The question is why the dipping AMH levels, does it signify that at some point the testicular tissue was viable and progressively there was senescence?
It may be there, sir, because child had scrotal fusion. That labioscrotal fusion was noted. It may had a role in the. As we are aware that 46XY gonadal dysgenesis, the things occur before the virilization occurs in the early embryonic period. So at that time, it would have just caused the fusion of the labioscrotal fold, but no enlargement of the phallus. So it would have had functioned in till certain point of time. I felt like that.
And I think what Dr. Kanishk also said, that the histology is the key to this. And I just wonder whether there was any ovarian tissue which was missed.
Yeah.
Because
so,
pure gonadal dysgenesis, you really have nothing out there.
yes, sir. Yes, sir. So
And
this,
when you have a mixed, architecture,
sure, sir.
then it moves differently. Then it's a mixed gonadal dysgenesis.
So we may clear it with the second child because the diagnostic laparoscopy and this is still pending for the second child. So it was not. I was not aware of the first child will be having all these findings. Only when we got the mutation in the last 3-4 months. Now we are going retrospectively and analyzing. Now anyway, the second child still has to undergo the diagnostic laparoscopy. We may get some details in the child. We may look for the ovarian tissue and the detailed histology of the testis, whatever is being found. We may have to look into that.
The last comment is that now genetics has come in a big way in helping us out, and especially there's some labs which will do a XY DSD panel,
Yes.
or XY DSD clinical exome or whole exome. Now it may throw up, like in this instance, a VOUS, a variant of unknown significance, and then we jump on that, and then I was wondering what the term made in silico.
Yes, sir.
I mean, who projected this? Did you get it from some other database?
No, I just checked in the Genomad database and Cleanver database, and I checked it off. It was fitting for that. Sorry, Varsam.
Because this, of course, enriches us in the sense we are now getting lots and lots of mutations which are associated with DSD and something else.
Yes, sure, sir.
And perhaps, in the DSD session, which we'll have in the next couple of days, we will talk about the genetics. But one concern I have is that we may be coming up with false labels as well.
It's true, sir. That's really true.
And at all times, genetics is helpful, but we have to put all the three things together.
Sure, sir. I agree with that. That's what we are not getting clear inputs from the geneticist regarding whether to consider this as significant, because we have 2 siblings I could come in. I have a series of 24 patients where only 4 I could prove pathogenic. Remaining I am in a dilemma because they are having a good testo production, so I couldn't come in. So, and difficult to assign the sex of rearing, as you are all aware of that. It's a.
But here, was the sex actually assigned at birth?
Yes, sir. They were thinking it is female only. I had seen the child on day 4 of life, the first sibling. It was female. But when they realized there was a fused labioscrotal fold, then only it came into the attention. Otherwise, it would have got missed till now. Then when they delivered a second child, they realized it has a similar findings, and then we had to do the evaluation for the second child.
Well done. Very well presented.
Thank you, sir. Thank you, sir. And thank you, ma'am.
Yeah. Can I just echo those comments, because I think it's very true. The problem with VUSs is what do they mean? Most geneticists are extremely conservative, and they're not going to call it pathogenic unless there are reported cases and it's been proven in an animal model. A number of my academic colleagues, have a more pragmatic approach, which is if you have an in silico pathogenic mutation, if that mutation follows something which is already recognized, then they'll accept that as a very likely cause. Slightly more difficult here because the TOE, there is some evidence that it causes gonadal dysgenesis, but not a huge amount. But I think given that it's pathogenic and given that there are a number of other cases, it's probably the cause. But as I say, it's only probably. That's what remains a VUS. So there is that ongoing tension about what it actually means. And I guess as the databases build up, we'll be in a better position. And the more patients they have, the more likely they are going to call it a real cause of the underlying problem. So I absolutely agree.
Yeah, I just want to comment on that. So the cases which have been reported by the series which I showed you, they also the genes are not pure pathogenic. They had found a MRI having a cerebellar hypoplasia and the gonadal abnormality. So they correlated in that way. Maybe our child, we have to do an MRI and then confirm it of the etiology.
Yeah. The other thing I just wanted to ask is management, because you're raising as a female, but those genitalia were not normal. Are you looking at doing genital surgery, or how are you discussing it with the family?
So I need your suggestions for
Did you understand?
Yeah, I need your suggestions for
Shall I answer your
Yes,
question?
please feel free. I'm putting it to the group as well, so I'll be interested to see what other people
Yes.
think.
In our cultural context here, they have already raised the previous child as female, and I'm sure they must be keen to raise this child also as female, going by the phenotype. So normally we would go the binary way, accede to their demands after an entire discussion, document it, and then go ahead with feminizing genitoplasty as and when they wish, if they wish it now or they wish it later, put across the pros and cons to them, and be aware that it is dysgenesis and remove the gonads. That is what we would do in
Thank
this
you.
cultural context. Yeah, timing of gonadectomy. Yes, there are two ways that we would put it across and discuss. One, because we know if we have that's why I was very keen on the histology of this gonad, because with histochemistry, etc., there are telltale signs that yes, this is likely with OCT, etc. So we would look at all those, and if available, then we have a strong reason to go ahead with an early gonadectomy, because we know the rates are prohibitively high in dysgenetic gonad. So we would advise for an early gonadectomy in these.
I think this brings up another very important question, which perhaps we should deliberate today and more in the next DSD meeting. Is sex of rearing and surgical, interventions, because now globally, any mutilative surgery, irreversible surgery, is being frowned upon. And so, even in this case, where the sex of rearing was female, these questions, when you do the feminizing genitoplasty, and if there was a 9mm microphallus, when do you remove that? Because a girl who is now in school cannot, void properly, or somebody else sees them, and there is immediately this concern about DSD. So timing of the surgery is something which all of us can, think about and talk about perhaps.
It's interesting you're having the same issues that I think are occurring around the rest of the world in Asia now as well. But I think those discussions are very important, and I don't think they necessarily have a clear answer.
And that's why this multidisciplinary team is of extreme importance.
Absolutely. Can I ask from the Philippines, is this the same approach that you would use?
Yes, basically. I mean, we have to see what the phenotype is and then proceed with genotype and for further diagnostic studies.
So this is a kind of testicular regression syndrome. It's the wide variation of the onset of the regression starts. And this patient may have the androgen shower during in utero, right? Because the regression starts relatively late. So what would be the gender identity in this
It's still
patient?
yeah.
Yes, you don't know still?
Yeah. 3 years is just completed. We had to do for
Right.
that now.
Yeah, okay, yeah. And regarding the gonadectomy, yeah,
In your country, when would you assess for gender identity?
well, up to 2 years, there's not the gender identity is not established, but earlier the cases, after 2 years, maybe the gender identity has been somewhat established. So after that, we may looking at them very closely through a psychologist. Yes, and we may follow up to the pivotal ages, because the gender identities fluctuate, male and female. It's very common that there have fluctuation between male and female.
Yeah. And you're into Thailand, same sort of approach in Thailand, or?
In terms of the gender assignment, I think we go with the phenotype and how it never been perfect. It will never been perfect with either genders, but we go with what might be probably more beneficial for the child. But we would discuss with the parents and we give all the informations. So in terms of the timing of the gonadectomy, we would do as soon as possible if the child is ready, maybe at 1 year or even before that.
So I had a question, so actually myself. As a test 2 level, is there going to tell you the sex of rearing? Some say more than 200 nanogram per DL is a good response. Some say more than 100 nanogram per DL is a good response. Some say even 50 is a good response. In our child, the value was something around 37 and all that. That can be the testosterone levels, because as discussed, they will have an imprinting on the brain in the early period. So 50 is a quite good value to have a imprinting on the brain.
It's really, I don't think we have enough information to make that call. It'd be wonderful if we had a cutoff, wouldn't it? But I think it's a gradual thing, and there are lots of other impacts on your sex identity. We know that how you're raised in that first 2 years makes a huge impact. So you can have 21 hydroxylase deficiency who will have testosterone levels which are triple or quadruple what you've got here.
Yes.
And if they're raised as girls, they identify as girls. So I don't think it's as simple as looking at the androgens, although they clearly do have some impact.
Okay.
Your DHT level, was it high for your assay?
It was normal for the things.
Why was the child's external genitalia not more virilized?
That was the doubt in our case. I could find only the fusion of the labioscrotal fold. Apart from that, there is no increase in the phallus size. The explanation is not aware of that.
Anyone? Since the time's sake, it will be the last question. That's
Thank you. Very nice presentation.
Thank you, ma'am.
So, is there any tumor risk?
Yeah,
Has it
is
been
there.
reported? How much is it in the previous studies?
Not about this study, ma'am. Not reported, actually.
Not reported in previous studies.
Not reported.
So, being a partial or complete gonadal dysgenesis, gonadectomy should be done for the tumor risk.
Yes.
And I think early gonadectomy, like maybe less than 5 years, whatever you would say, ma'am. I'm not aware in this case. And regarding the gender of rearing, here in this case, it is relatively more easy because it's a gonadal dysgenesis and all. But suppose it was a partial androgen insensitivity. And then the parents start demanding that it's an XY. So we would like to rear like a male. And even we are not aware that how much they would respond to testosterone. So maybe if the second case, maybe you'll be discussing. So that is
okay.
Okay, thank you.
Then let's move on to the second case.
Okay. Thank you. Thank you.
Thank you very much. Nice presentation. So then we will invite the second, Dr.
Ashima.
Ashima. Okay, Ashima.
So, very good afternoon to all. I'll be presenting this case on behalf of Dr. Divya Lakshmi, my close friend, who could not reach in time to start this SIG. So, please feel free to stop me because I think I have more questions than answers to the case as I present, but I'll take you along the case. So, this was a 10-day-old baby who was born with gender of indeterminate status and was referred for abnormal looking genitalia at birth. There wasn't really much in history except that yes, the call that was received was related to an abnormal looking genitalia. Even in the emergence, even in the nursery, nobody could actually like ascertain what they meant with what they were looking, and that is what the description was. But the good thing was the neonatologist could notice and palpate bilateral gonads. So at least he knew that it was something. It probably would turn out to be with an XY. And they had sent the baseline screens in terms of 17-OHP and cortisol, which I think would be crucial for managing any baby who gets born with abnormal looking genitalia. So both of these were normal. There was not much in the birth history. This was like no complaints in terms of pigmentation, poor weight gain, or any feeding difficulty at that time. And antenatal history was also not significant. Maternal age was just 26 years. And after birth, there were no documented episodes of hypertension, hypoglycemia, any seizures, or any other complaints. This was a second born to non consanguineous parents. And the elder brother was a normal looking brother, I mean, no problems, and was healthy. There was no family history of any other like distant cousins having ambiguous genitalia, any infertility issues, any reproductive problems in any of the members. So at examination, so this is the newborn that we are looking at, and this appeared like a well child. There was no hyperpigmentation, no dysmorphism. Anthropometry was pretty much a healthy, good weight baby. Vitals were all stable, and this was the genitalia, how it looked like. So as we can see, there are labioscrotal folds, but they are clearly bifid. There is some rugosity and like a normal sort of a pigmentation that we see. Bilateral gonads were palpable in the labiosacral folds, and the phallic length, though it was very small, but around 1.2 centimeter. There was a single perineal opening, so the baby was passing urine from this single perineal opening. The EMS score was 4, and the anal position was at the normal position. The other examination was normal. So here we had a baby who was severely undervirilized, had to be probably male, with penoscrotal hypospadias, a micropenis, bifid labiosacral folds with palpable gonads, and there was no other syndromic features. So initially, the first differentials that we would keep and would come to our mind would be something which are very standard in terms of 5-alpha reductase, partial androgen insensitivity, and yes, other enzymatic problems in terms of 17-beta HSG3, and probably an isolated anatomical abnormality was one of the defects that were kept. So this is how they had planned to approach the case, starting with basic baseline hormonal profile, if need be then a stimulation test, a karyotyping, and which may further warrant the need for a whole exome sequencing, and yes, supportive imaging to find out what is the status of the internal gonads. So these are the baseline investigations which we can see here. And this was at day 10 of life, so it was the LH was also high. Testosterone was almost in the normal, I would not say very high, but yes, there was some testosterone production. Cortisol was normal, 17-OHP was normal. So this is from the extended LCMS assay that they had sent at day 10 of life. Androstenedione was normal here, TSH was normal, electrolytes were normal, and the karyotype was 46XY. At this baseline investigation, the TDHT ratio was 2.72 and the TA ratio was 2.1. So here, nothing much. So a TA ratio of less than 0.8 would be something that we would be worried about. But here, even this ratio appeared normal and at the first testing. They did an ultrasound abdomen which showed absence of any Mullerian structures, and there was nothing except that yes, they could identify both testes in the labioscrotal folds. So we are here looking at a baby who is a 46XY. There is non-visualization of Mullerian structure, so it's just an XY that we have, but he's severely undervirilized with a very poor EMS, very low EMS score. And on baseline investigations, the LH is a little on the higher side. Normal levels of testo, THD, and andro. So, any comments from the house? What are we actually wanting to investigate next here? What would you next?
Anybody want to put their hand up and ask?
I would still not rule out 5-alpha reductase entirely just because the TDHD is not fitting in. We know that some of them can be low, very low also. I would keep PAIS very much on the list because it fits into some of the things. And I really didn't understand what an isolated anatomical thing which you had put.
So
Maybe you
even
could-
she has actually put it as one of these, but probably I wouldn't consider that because the testes are descended and it's a clear-cut virilized, under-virilized male. So probably I'm also looking at androgen insensitivity and maybe some biosynthetic defects, even though they didn't show on the biochemical baseline assay, but something would have gone wrong somewhere in the pathway which would have led to this under-virilization were my thoughts also.
Besides what you've suggested, I think a genetic assay here would pinpoint it towards a 5-alpha if it is, because the phenotype looks very much like a 5-alpha. So I think I would bet on the genetic. That's not in.
What about the family history? Maybe.
There was no family history of
like,
any other.
infertile aunts and.
No, that was asked. That was clearly asked, and I confirmed with Divya yesterday that
There's
there
no
was.
family
I mean, till the 3rd degree pedigree, and this was a non-consanguineous family, non-consanguineous marriage. So basically, the next pop-up that might come is something that I was also not very comfortable with. Yes, ma'am. Yes, ma'am.
When we speak of isolated anatomical whatever defect which is mentioned here, the phallic size should be good. Here you had a phallic length of just 1.2. My surgical friends do think that when you have a penoscrotal or a perineal hypospadias with a normal looking phallic length with both gonads descended could be an idiopathic isolated variety and it may not be a spectrum of DSD. But since you have a low phallic structure, maybe there is an underlying DSD here.
So, ma'am, just one question for my understanding. If it's a hypospadias, how would we ever get a phallic length which we would say is normal?
So that is what the idiopathic is. So when
Okay.
you have like an evolutional and post very late stage of your embryology, if you have some degree of receptor insensitivity or underproduction.
So there would be some phallic length which
If you
would
have
formed.
a good phallic length and you have an isolated penoscrotal or mid shaft or even further, we say that mid shaft coronal glandular
They no
hypospadia
longer
is
need.
not, they're
Yes.
all just not DSDs.
So it's not true in all the cases, ma'am. They may not have a micropenis in all the cases. So as she had presented, like we had a normal phallus size with the EMS of 9.
Yes.
Proved to be 17 beta HST.
Yeah. I do take your point as well. That's more to reiterate the fact that everyone, even with an isolated hypospadias, needs a thorough workup, though they may be idiopathic. We ourselves have found about 6% of these children having an underlying genetic defect. So though it's just a hypospadias repair, there might be surprises when you do the genes. You may not get anything on hormonal evaluation, but when you do genes, maybe you'll be surprised.
As testes are descended and functioning well, so that may not be a problem in these cases. So do we work up? Yes, ma'am. Proximal and penoscrotal, where the EMS comes less than 9/12. So yes, ma'am.
Sometimes these children go, I'm sorry.
No.
They go directly to the surgeons for a hypospadias repair, and they find a good phallic length to correct, meaning a penile size to correct, and they find an isolated hypospadias, they correct. They do the surgical correction. That's how the story usually goes. And then they get referred to you later on for evaluation.
This definition of a perfectly normal phallus in the context of this muddied waters is actually very difficult to state, because you can have isolated perinoscrotal hypospadias with a microphallus with chordae and be absolutely, structural. But in this point, I think what Dr. Sudha is trying to say is that if you have a small phallic size, then do not label it as isolated hypospadias and go for surgery and forget about it. The other piece, although you may be coming to it, and I agree with Dr. Kanishk that sometimes these values are, total scatterplot. They just don't fit in. And also depends on when you're doing the samples. You're doing it 1 week of age, 1 month of age, during the time of mini puberty. In my experience, which has been somewhat there, I try, if I have to do blood tests, I do it during the period of the mini puberty. So then I do not have to stimulate them. And I have been a little lucky in using these biochemical parameters to actually come to a diagnosis. But having said that, over the years, I've been doing it for many years, 20 years really. What I have now come to is after a multidisciplinary team evaluation, surgeon, psychologist, ourselves, geneticist, and pediatrician, of course, we try and get to a sex of rearing by 2 weeks of age and try to expedite all this. Karyotype, as you know, takes 3 weeks. We typically do a fish, so we have a result in 3, 4, 5 days. Now, one piece which has come, this is a continuum of the statement from the first case, is sometimes we get lucky. And recently we had 2 cases with 5-alpha reductase deficiency where we did this XY DSD clinical exome. And it showed that. When we look back at the numbers, I agree. The DHT wasn't, sub-zero. It was out there. You just couldn't interpret it. So I think, this is my messages, that if it is up there, very, very prominent phallus, with everything else looking clean, with, both the testes descended, chances are those patients may not need investigation. But in this case, you certainly need investigation. I really don't think a lot can be achieved by just looking at those levels and then come to a conclusion. And I would do a 46XY DSD panel in this case and see what it shows.
Can I just add one last thing? Your data, I think, is useful with a normal cortisol. And with a normal cortisol, that generally excludes a lot of the DSDs that are earlier. And so really what you're looking at is the big 3, aren't they? We're talking about 5-alpha reductase,
Yes.
3-beta hydroxysteroid dehydrogenase, and partial androgen
Partial
sensitivity.
androgen, yes.
And the partial androgen sensitivity is less likely because your testosterone is not high. That makes it a bit less likely. Definitely not, but those are your big 3.
Yeah.
So I think that's one of the pluses
Just
of doing
hovering
this.
around a cutoff is
Yeah.
what my tester is here, right? So they went ahead with the whole exome sequencing, and this is what they found. They found a mutation in the HSD 17 beta HSD gene, which was like a likely pathogenic variant here, and a compound heterozygous variation. So at this point, I was not sure why they wanted to do an HCG stim test and whether this was done, I think, after they had got, or maybe simultaneously sending the whole exome. So my question to the house actually is, how many of us would want to do a stimulation test here when the baby is, I think, 2 weeks old now? By this time, he's 2 or 3 weeks old. Perhaps I wouldn't have done a stimulation test, but I think they wanted to raise this question to the house where she feels there are some people who still like to confirm values on a stimulation test. And looking back at numbers, I think these numbers only confuse us further.
Absolutely. We don't know the cutoffs. I mean, I think
And
we
if you-
don't know the cutoffs.
Yes, and if we look at the stimulated levels and the baseline levels both, they are actually not fitting into a 17 beta HSG biochemical phenotype either.
But they
I
exclude
mean-
5-alpha reductase.
Yes, ma'am.
I'm sure it's available in Delhi and also in Chennai and Bangalore. It is an ACTH stimulated 13 steroid panel.
Okay.
If you do a 13 steroid panel, you got a genotype of 17 beta HSD. Your 13 steroid panel might help you to see how the progesterone is, how the pregnenolone is, your DOC, and the rest of it can help you.
So, ma'am, my question actually after this case was, after having stopped at knowing it was a 46XY with no Mullerian structures and with a clinical phenotype of probably a partial androgen, what do I do next? Do I ask my patient to go ahead with a whole exome, or do I do stimulated panels? Yes, sir.
I think a lot of discussion going around the emerging role of genetics, and I think XYDST is a very, very muddy picture, as all of us are talking about. I think in this case, if your testo is going up to 200 and this, and you are having 17 beta HSD, the best way would be that probably the approach should go forward towards a routine genetic screening, which Dr. Subrata also talked about, because we have seen so many discrepancies in the genetic and the biochemical picture that we don't rely much on biochemistry. So I think normally what we are doing now is that if we have XY-DST, we have ruled out some of those biosynthetic defects, there is no hypokalemia or salt wasting, then we probably go ahead with genetics, because this causes more confusion rather than getting
Exactly,
into it.
and the stimulated panel, even if it was done, it was not answering
And
any of the
stimulated
questions.
in somebody whose LH is 14, we don't need to do stimulated. That's I think
Yes,
pretty much
yes.
clear from there.
So actually, the steroids should be done with LCMS, MS. So we don't know about this assay, whether it's reliable or not, androstenedione.
I think the first one, ma'am, was an LCMS, but this one, I think the stimulated panel was not.
Yeah, level is really high
Yes,
for 17 beta HSD.
yes. And I mean, this was a compound heterozygous mutation, so whether that led to a difference in the genotype and the phenotypic presentation, because this was perhaps this was not a homozygous variation mutation which could have caused a problem there. So I think the only point that I would want to stress on the management was the role of a multidisciplinary team here. This looked more like as decisions were taken for the first case, where knowing the clinical phenotype which guided the gender of rearing. Here the gender of rearing and the karyotype was a 46XY. So they agreed for a plan to rear this child as a male, and with staged surgical corrections that this child will need. And again, for parents, the genetic studies were not done. For this was the second baby. The first baby was normal, and then the parents, I think, decided not to go ahead with, probably not, they weren't planning a third baby at this time. So this baby is planned for surgical management of hypospadias at 9 months to 1 year of age. And parental concerns were gender of rearing, but I think for now they've agreed to a male gender of rearing. And this is what Dr. Divya also wanted to emphasize, is how in their state they have now a government order in place where the decision for surgery in children with DSD cannot be done without involvement of an MDT, and that MDT should be constituted with members who are psychologists, a social worker, the parents, surgical colleagues, medical genetic colleagues, everybody. So the prognosis have been explained. At present, the baby is 3 months old and is thriving well with an SPL which has just grown a little, around 1.8 centimeters. So I think we can stop here. The rest are just theoretical slides on 17 beta HSD, which we can avoid.
Thank you. Can I just ask,
Yes.
did you give this child testosterone?
I don't think, but the SPL has grown. She's not mentioned. She's not mentioned, but
Then you saw the stimulated value. I think
But the testo is not
went
low.
way up out there.
Yeah.
And someone who's got this 17 beta HSD, the conversion is inadequate.
Yes.
So this again underscores the point that these numbers are scatter plots. And to hang our hat on these numbers and come up with a brilliant conclusion sometimes may be erroneous. But yes, I would give testosterone to this patient.
So, sir, would you give it after the 3 months or 6 months once the
well,
decision
this
is to
phallic
refer to
size,
the peds
I mean,
surgeon?
you have plenty of time for that.
Yes.
Typically, what I do is I work with the pediatric surgeon, they evaluate, and then they normally operate at 15 months. Dr. Ganesh will be able to help us to 18 months of age. If it's 2 stage, 1 stage, they can do it 18 months. So prior to that, we try and prime them up. But one advantage of using testosterone is the response. And oftentimes it can be a discriminator. I mean, I used to use it in many days, those yesteryears, where PAIS versus 5-alpha HT. And PAIS, the response would be very, very poor. So the reality is, at this point in time, I think we have stumbled on genetics, and it cuts both ways. It brings a boost with exotic diagnosis, or it may confirm something in this instance. So I think 2 sides of the same coin. Thank you.
I have one more question to the group actually. How many of us would want to use local testosterone in babies who need repair, surgical repairs? Because I think surgeons do use it very often to improve chances of, to improve outcomes of phalloplasty.
I think a larger penis is always easier for a surgeon. I
Yes.
think
So
they
how many
prefer
of us
it.
do it? If yes, how many months? For how long would we use it? Like if in this baby we were to start.
I think normally like we do like 3 shots of 25 milligram of testosterone depot,
Yeah.
but for the PAIS or alpha reductase deficiency, sometimes we need more higher dose and more doses as well.
Thank you. Any experience with topical testosterone?
Yeah, we usually use the DHT ointment.
Okay. Cream.
Or cream you may have. Yeah. Yes, all the cases.
So, as Sir said, testo is 821. So, if you give testosterone again injections, it won't act. There could be some amount of androgen receptor resistance at the level. So, we may try with the local because 821 is not acting at the thing. So, if we give another testo, it may not act. They may have some amount of resistance at the gonadal level. So, some amount of androgen receptors, which they actually term it as PAIS type 2. So, could it be there in these cases? And the second one is the question is, but 821 of yeah.
821 was a stimulated level. The baseline was around 200 nanogram per, like 188 and then 200 nanogram per
Day
dl.
4 they have done a stimulated level was a question again.
No, they did a stimulated perhaps after a few weeks.
Okay, fine. And one more thing is, as you all are aware, HCG stimulation test is not reliable most of the time.
Yeah.
So one case where I found in 2-3 cases was baseline mini puberty were less and they were normal. Testo stimulation test was like not showing any response. Second time I did a stimulation test, it showed a response. And we are using a company name here by HUCOG. I am not using a recombinant HCG. Is there a difference in using a recombinant HCG versus the regular HCG we get? Does it show any difference? And I follow the protocol of 1500 IU once, and then I do it after 72 to 120 hours. There is a different types of protocol. One uses 500 daily for 3 days, and then go ahead with the test. Is there a difference in that? Was I wrong?
There are as many HCG protocols as there are endocrinologists.
Yeah.
That's the bottom line. They give a lot over somewhere between 1 to 3, sometimes 4 days, and then do a repeat 1 or 2 days later. It doesn't matter so long as you're giving around 1500, give or take. I don't think it makes a lot of difference.
So why there's a different response on same patient, 2 different response. One was testo was less, and there was 110. It's a good response. I don't know. It was done outside. Then I did the stimulation, so it was more than 100. So I couldn't attribute. So we cannot say the child is not producing enough testo. It is producing.
Yeah, just to add the surgical point that you raised, we use testosterone or the preparation, intramuscular preparation, or the cream if available. DHT is very sparsely available. It's not easy to get the DHT cream. So we use them in all except the androgen insensitivity, because it's sometimes very difficult to know what the heterogeneous partial is or not. Where we know it is not going to work. In the rest, we use it pre-surgical, but there is a caveat there that we have to finish it 3 weeks before the surgery at least, because it does increase the vascularity, and there is a controversy as to whether it causes more problems at surgery besides bleeding and healing. Although it makes the phallus look larger, gives us more tissue for repair, etc., but it has its negative side also. So one weighs this, and then it's a decision whether we use it or not.
Thank you, sir.
We have been conventionally using the intramuscular preparation once a month for 3 months. Yeah, but the testosterone cream. Testosterone cream. Yes.
Need the cream. There is an ointment
As a
also.
cream. It's available now.
It's
but
available.
DHT cream is not very freely available.
Even testosterone cream is now easily available.
That
Earlier
is
it
easily
was mixed and then it was dispensed,
Yes.
but now my patients are actually getting it. So they have to be wearing. Yes, this even I tell them.
Exactly. Yeah, it's with an applicator with gloves so that it doesn't, so that you don't smear it elsewhere, and the person who's applying it also is not
Doesn't
exposed.
get it. Yes.
Locally. It's applied locally, the testosterone cream. 3 to 4 weeks, and then stop, and then operate after 3 weeks more.
Yeah, well, we can't hear. We can't hear. It's all right.
So, how early can we advise surgery, sir? Because as soon as we come to a diagnosis,
Yeah.
the parents are more in a hurry. They
Yeah.
feel that this kind of a repair needs to be done early. But since we have a lot of problems with relation to the surgery, the
Yeah.
timing of surgery, so
Yeah.
what would be the ideal age?
In 46 XY DSD, except the very feminized forms where there is a big question, just like there is a big question in timing of DSD in the dysgenesis, etc., where it's a female phenotype. In the ones where it's more towards the male phenotype, one can go ahead with surgery, as in the non-DSD hypospadias, which is they have said that they're going to do it in 9 to 16 months. We may delay it a little more to the second year of life, so that that's a general thing which is done. Where the tissue available is very less, some surgeons would prefer to wait a little longer, unless, of course, the parents want to postpone everything for a later time. So 16, the second year of life is a good time to do that.
Thank you, sir.
Okay, got time for 2 more questions.
Till what age would you like to give testosterone injection without worrying about the advancement of bone age? So, like generally we stick to 2 years, but many times even up to 4 years. So, is there any recommendation you could find regarding intramuscular testosterone? And DHT gel is generally preferred because it's a non-aromatizable, so it doesn't lead to advancement in bone age. So, it's preferred over testosterone, though it's a little expensive. So, I just
What
want
is
to
the
know
trade
about
name of DHT cream?
Andractim gel. Andractim gel.
And is it available for you?
Yes, Jolly Pharmaceuticals.
Yeah.
Yeah, so we ask patients to share. They can share amongst themselves. But about testosterone injection, I'm a little worried to give at around 5 to 6 years.
So, ma'am, do we?
Yeah,
The doses are also
very
important,
less.
because
25.
25 milligram, I've been using for a long time.
Till what
Once
age,
a
sir?
month for 3 months.
Till what age would you use?
About 3 years. Yeah. One point, just to round up this genetics discussion, you remember the last line you said, the parents were not interested in another child, so they didn't want to go ahead and do their own test. Is it compound heterozygous?
Yes.
It's very
Very
important to
important.
establish. And I'll tell you what the genetics colleagues do. They just, wham, this is what they say. We're going to test the baby, and then positive, we're going to test both of you. Okay, got it, Gavish? That's it. Because when you go back and they realize the baby has a problem, the first thought is, I'm not going to have any more children, and I'm not going to test. Why? I don't want to find out who is responsible for this. So that is why it's something which they should understand up front. When you're doing genetics, we're not fishing, trying to prove a point, and they both have to, it'll be easier, it'll be Sangas after that. So it's going to be much cheaper. So this is one very important point, which is really a kind of a housekeeping point.
Yes, sir. Thank you. And I think even I sometimes learn the way they counsel, because then the parent agrees for going ahead with a genetic test. For us, it's sometimes less convincing. I don't know. Maybe to learn from them. Thank you, sir. I think I hand over to
I
Chairperson.
just,
Yes, ma'am.
if you can, and then I'll like to have your opinions about use of testosterone. I think intramuscular testosterone has a lot of, parental testosterone has a lot of, what is it called, effects which are not wanted. So local testosterone gel or cream, whatever we have, would be useful. And we'll have a controlled way of monitoring as well. And like I heard recently that if you put testosterone in an adult, those who want, say, increased libido and all, even on the shoulders, it gets absorbed quite well. So it's not necessary that you need to put it on the genital area to make it absorb. So the absorption and the effects of a cream or an ointment is as effective as intramuscular. So intramuscular has its own disadvantages. So maybe we should rethink our practice and try using testosterone locally and then see how you can even put it on the shoulder or anywhere else, it will get absorbed. The other thing about DHT cream, for its effectiveness, when you do not know, it is in centers where you can do DHT levels easily, you could look at the levels pre and post to know the response to your the tinned whatever it comes from Nath pharmacy, whether it has DHT or not. That will also be known if you do a level prior and after. Maybe what is your comment on parental versus local?
I'm just wondering, we're 2 minutes over now, and I'm just very aware of keeping to time. So perhaps we could talk about that afterwards, which I'd love to do. I'd like to thank Shima, which there's a brilliant presentation. Thank you. And I'd like to thank both our speakers. So that's both today. Thank you very much, guys. Thank you very much. This has been a great session. The interaction has been phenomenal, and that's what we need, because this is an area where we need to share information, and we need to share our approaches and our philosophies. And then what's happening in Tamil Nadu is what's happening around much of the world with multidisciplinary teams. I think that's exactly the way we need to move forward. But hopefully we could talk about that more in the next DSD symposia later this week. But thank you all for attending today.
Thank you very much. APIS have the DSD working group. Paul and I chair now. And if you want to join, please let us know. And we will discuss about the cases on the occasion, occasionally. So please let us know. And we are trying to have this kind of meeting at the APIS scientific meeting. So thank you very much for your participation. Thank you.